Saraswati Bandana. Now I introduce our first surgeon for this evening's live workshop, and she is Dr. Chaitali Basu, who is from this very hospital, Southeastern Railway, and there's no better way to begin this live surgery than with an Aryan. You know Aries as the first sun sign, and they are the initiators. They like to take the leading role in any kind of endeavor. So Dr. Chaitali Basu is an Aryan, and today we are going to see her dynamism as a young and vibrant surgeon. What according to her is Phaco? This question was put to every surgeon. What is Phaco like? And you know what she had to say? Phaco is like driving a Lamborghini. So you can imagine, Lamborghini, it signifies style, speed, power. So we are going to see something like that in her surgery. Coming to something personal about her, it was also asked who were their favorite actors. And it was Tom Hanks and Audrey Hepburn. She doesn't believe in Bollywood. She only believes in Hollywood. So this is her taste and style. So maybe this is also what she does in her surgical skills. And her favorite music director is Sholin Chaudhary.
Hello. Can I get anybody in the OT?
Sure, Ajana.
Hello.
Hello, Ajana, can you hear us?
Yeah, is it on now?
Yes.
Yeah, we'll start with the first case, is it?
Exactly, she's ready, and so is Dr. Asipal.
Okay, Manjushri Roy, I think this is the first patient, isn't she the first patient?
Yes. This is the
Yeah.
patient.
Okay, so this is, yeah, I think we can, this is a grade 1 to grade 2 cataract, some posterior subcapsular part. We have seen axial length 22.42 with K1, K2 within point, and the difference is within 1 diopter. So we are going to put a IQ lens, as I suppose, and it's a 23 diopter lens. Yeah, come on, let's go to the OT. Yeah. Dr. Paul, yeah, we have both Dr. Pauls here. Anyway, yeah. Rotish, I would call him, and Ajoy here. So here, what you are seeing, she has made a very small incision, a 1 mm side port incision. That's what we call. Unlike the first surgery, until very recently, what you are doing, you must have seen a big bud barker knife making a big incision. What she's doing, yeah, can I get you, Chaitali? Yeah, she has just stained. This is what. Yeah, Rotish is there. He's an excellent teacher. He has trained, I think, almost all the surgeons that are here now under a Phaco development program. So, Rotish, do you advocate that staining in almost all cases for the beginners, or even for persons as veteran as you yourself?
It is probably a good practice to stain over it.
Yeah, that's absolutely
I was
nice.
talking to Chaitali, I think this is a nice practice to start practice with the type of, because that is most academic.
Yeah. So filling with viscoelastic, the whole anterior chamber, and unlike the earlier surgeries that we had where the eyeball used to lose its, the contour. Here it's a closed surgery. I mean, that's how phaco-emulsification, the latest surgery, wins over all these surgical that we have been doing over the years. The techniques. I think here she is making a cystitome. Now this is a 26 gauge small needle which we bend the tip and just to open the anterior capsule of the lens. And this is what manually made. Most of the time the surgeon makes it or the assistant prepares it and keeps it. Now this is again, just like Rotish said, a very good technique of entering the eye through the small incisions. Now you'll be seeing a bit bigger incisions being made later on, around 2.5 or 2.8 or 3, depending on the machine type you're using. The maximum size that we are using as of today is 2.8, and the minimum is around 2 millimeter. There's also sub 2 millimeter, sub 1 millimeter incision has come out, 1 millimeter, that's called microphaco. Now this is just that the lenses that we have now cannot go through those small incisions, so we're sticking to around 2 or 2.2 millimeter incision. And this is what you have seen.
I think that's Vijay,
Yeah.
an excellent demonstration. You can see that some of the viscous thing that came out, so she's again.
Yeah, refilling the chamber. Yeah, that's.
After refilling again, she has started. It's an excellent practice.
Just like I said, the eyeball's contour is being maintained. Now we could have complications, or we could have long-term complication if. That's one of the reasons why phaco-emulsification is in the earlier surgeries, the eyeball used to lose its contour, so you could have a late complications like retinal edema, the retinal detachment, etc. What you are seeing is a deft work of the hand, continuous curvilinear capsulorhexis. Now this is the term that we use. A continuous round curvilinear central CCCC, continuous central curvilinear, yeah, continuous, that's it. And
It's great, although the thing is to be appreciable.
yes, absolutely. I think she can match your femto, yeah, the femtorexis that you do. Now the latest,
Don't be femto.
it's not femto, but then,
Excellent, I am telling you, see, when she was deciding, I asked her what type of cataract is. She said, I give the other eye on last Tuesday only.
Okay.
And she knows what exactly happened. So while she was deciding the size of the rexis, she decided that it is a soft cataract and harder cataract as usual. She was with larger rexis of optimal size. So this is excellent. She had performed, and I think it's now the rexis is performed. She will be preparing for
the main incision, I suppose?
yeah, she is preparing
The main incision.
So she is planning the three-planar incision. So the initial plane she has made with a white pepper plane, then has taken a 2.8 carat. You can see the 2.5 mark.
Yeah.
She is weighing 2.5 mm across in the mid-stromal plane, and she is maintaining the plane. And she had some difficulty with the knife, so we will be changing a knife, another incision knife.
Again, she's refilling the anterior chamber. Now this is again a step to get the right incision plane, to get the eyeball should be maintained. This is a valved incision, the incision which does not require any suturing, etc.
She has changed the blade, and with a new blade along with the track, she is just first localizing exactly what length she had went, probably around 2.5 millimeter. And then she entered into making a 3 millimeter length incision.
Yeah.
And you can notice also she started her incision starting from the mid liver zone. Just you can notice some blood is
Yeah.
just for the
That helps in earlier healing, I
This
suppose.
is also very interesting. You can see the nicely she had put a 1 millimeter incision, that is in the clear cornea, that not on the mid-lingual zones, in the anterior lingual zone. So now she is decompressing the anterior chamber, taking out the viscoelastics to make the space for the hydro procedures. Then you can see a beautiful fluid wave has gone through.
Yeah, I think that was noticeable. The nucleus is tapped, just a little bit of here and there, and there is beautiful rotation. The lens has moved.
This is superb.
This is superb. This is one of the holding the nerves in front of so many people. This is one of the steps which in the learning phase takes repeated procedures to master this with a small hydro, then you rotate the nucleus. Now this is where teachers, yeah, she is using a blunt chopper, yeah, that's it. Devashishda, could you just, I think there are some ophthalmologists here, something to, at this stage, as Rotish, Devashishda would make a little bit of point, I think, as the surgery goes on, as one of the pioneers of cataract surgery in this country and who has taught a lot of younger surgeons also.
She is doing very well.
That's it. Being, as you call them, novice, the beginner surgeons, but definitely she's doing it totally, everything is under her control.
So again the importance is this, you can see the trench direction and it is so straightforward, so she is maintaining in a totality from rexis margin to rexis margin this trench, and you can see the sharp wall which really helps her to break into two pieces. Initially she told me, sir, this is maybe too soft, so I may have to go for divide and conquer, but after starting, as usually happens in case of this medium grade of cataract, she has planned to convert it to stop and chop. So she made the initial trench, she cracked it into two halves, and now I understand, Roger, this is very difficult to chop.
Yeah,
but you see
she
is doing it so nicely, demonstrating so nicely. Would you like to comment something on the overlay?
Parameters, yeah, absolutely. There's maintaining around 350 with
This
the
part she is demonstrating well.
Yeah,
but
yeah.
do you like to comment anything on the overlay?
No, not
The
exactly.
parameters?
She's doing it absolutely right with aspiration rate 34 and 35 with a vacuum around 350, 23, 30, absolutely 1/10 that. And she's using an amplitude of around, so yeah, it's coming around 50, 60, the Ozil amplitude. Ozil continuous, I suppose this is.
This is continuous.
Yeah. And we can see the nuclear pieces are
Already
developing.
three quadrant she has taken out, the fragment has been removed. This is the last piece. So that's why she is a little bit slow. She brought it front, she is trying to support the PC as well as she is always keeping it up to date so that it should not stuck to the posterior capsules.
Absolutely, I would
So
just...
this is again a very good practice I would like to share here. Before removing the last piece, to put some amount of viscoelastics to make the anterior chamber more stable so that the fluctuation is less and so you are minimizing the chance of PCT. Absolutely, you can make it free.
Yeah, we are lucky in this generation. I can say that the Phaco learning curve in our days is to be very, very tough with those machines where you are seeing a very easily the nucleus has been chopped and all. Of course, the deft handling of the surgeon is there, but you're seeing the machines. We are lucky to have machines like these. Now, this is one of the highest end machine, the Infinity machine. Well, the sponsors.
Okay. That's okay, Ajoy, but this carries only 20%. Maybe if you ask
Yeah,
me
yeah, yeah,
20%
absolutely,
is
absolutely.
personal skill.
Absolutely, that's what I said. The way she has picked it up and chopped it and taken it out is,
You have to drive a Lamborghini, isn't it?
yeah, she is a Lamborghini driver, so the car won't go by itself. Absolutely. The last piece, again, she used the right technique, as Rotish has said, made the anterior chamber full, and this is where you can land up in a problem where suddenly
You can notice the character, the anterior chamber behaving, the iris behaving, the posterior. This is absolutely stable, absolutely stable.
stable.
And that's very important.
Since the nucleus
So
is
you
removed.
can, Ajay, you can
Yeah.
imagine the CD is 6.04.
Yeah, absolutely,
So
absolutely.
energy requirement comes
And
reduced down to zero.
it was almost a grade 2
Yes.
to grade 3 cataract, but then 6, anything below 10 is always. So you've done the bulk of the surgery. This is like a reforming the chamber and taking out the remnant of the cataractus, what we call the cortical matter, a little bit of cortex. Then insert the lens. There are a lot of surgeons who use a bimanual removal of an. Now this is a
And that's the correction.
Yeah, this is a coaxial way of removing the cortex, and the irrigation is coming from the 2 openings that you see, and the aspiration is from the metallic. This is a silicone sleeve through which the side of which the fluid is coming in, and so that's how you just point it down, finally polish a little bit of low vacuum. This is cumulative dispersion of energy. Now this is a calculation which it takes. There is earlier machines have Phaco time, Phaco power. How much? It's a calculation between the power and the time that you are using. Now, if you use more Phaco energy, Phaco time, that means you would be deleterious effect on the cornea, on the tissues inside the eye, because you should remember this ultrasound energy where the tip is vibrating at the rate of 40,000 bits, 40,000 times per second. So this, with this sort of cataract and this, it can go high if you're going for hard, but anything below 10 is absolutely fine. You could still have 12, 14, 16 for a harder cataract, but again we said the
Ajay, Chaitali is transmitting to me to share this experience.
yeah.
You can see as usual the problem with the question.
Yeah, that's it. That's I was just thinking of that.
Yeah, so she directed that.
Give me a bimanual.
No,
Yeah.
not bimanual. It is another.
Another aspiration.
No, not aspiration. She will be putting the implant first. Maybe if required, will be rotating it, and then again on the last part, where she will be removing the viscoelastic, she will remove this particle matter in the
Yeah, This is a surgeon's preference. I mean, many surgeons would use a bimanual from the very beginning, remove the and put in the lens.
What is the house opinion that those who are doing it, that use the bimanual or the coaxial?
I think present generation, I was the one of those surgeons who were trained in a coaxial, but then I suppose the present generation, almost every surgeon is trained in a bimanual technique. I don't know, I see very few of them.
No, one thing, Ajay, I mean, if you are using a coaxial,
still you can.
The first thing you should take the subincisional cortex
before.
And the first, because once the cortical
that support is gone, then this.
Now it becomes difficult.
Yeah. So this is a IQ lens, a yellow colored lens. Now this is supposed to protect the cornea. This is, the retina. The retina, and this, a lot of theories about it. This is a foldable lens, goes in through 2 millimeter and then slowly opens inside the eye, inside the capsular bag. The lens you have seen is basically a bag-like structure where the anterior surface has been removed, the anterior membrane has been removed, and we have put in the lens inside the bag.
Now this is also a very good technique, you know.
Yeah.
She's now put the lens and now
And
the
then-
cortex is scaffolded.
Mhm.
Actually the posterior capsule is scaffolded and protected by the intraocular lens. So, you know, she can be more bold in cleaning the cortex. So that's what she's doing, and this is, I say, you know, you always learn. So
Yeah, this is something
nice way,
definitely. I think the 5 or 6 surgeries that we'll see, I'm sure we'll see some variation of the technique by individual surgeons. Now this is where you're removing the viscoelastic. Now this is a part of the job that we do. We are replacing it by the fluid, that is a ringer lactate or balance salt solutions that we use in this, the fluid that you are using. You're removing the lens and removing all the viscoelastic from below the lens. And this is, it was a sheer pleasure to see this surgery. So well done, so meticulous. So at the end of the surgery, what we do is we don't close the incision. This is what you call the hydrating. You know, you put in some fluid, push in some fluid along the incision line, so that swells up and tightens the globe. And generally recommended is 4 to 6 hours. Absolutely, the eyeball. So, Shamalpita. Yeah. Tell me. Absolutely. A rep from the house. Absolutely. Absolutely. It was a great. It was a pleasure to see this surgery. I think everybody was enthralled. And as we come to